So now I'm going to talk a little bit about the model for improvement. That seems to, oh no, there's the model for improvement, and about your theory for improvement. And I think I started off with this, talking about the system of profound knowledge and Dr. Deming. And one of the reasons is sometimes we don't always have that clear idea of, if you don't understand the system that you're working on, then we don't know what we're going to do to how we're going to improve it. So some of that background thinking and introducing you to those concepts, that's some of the reason behind that, about understanding your system a little bit and how do we go about that. So the improvement approach, we started off about looking at our systems a little bit and about thinking about what might be the local barriers to change, what will be the resistance, what's the culture, some of that. Then we're going to do some work around what is our theory, how do we frame up a visual picture of what our theory for improvement is, and then have a methodology, the model for improvement, to go about our improvement method. So we link the system of profound knowledge with a model for improvement and the driving engine, the PDSA cycle, to drive our improvement forward. Now Jacqueline introduced the model for improvement, and not that many people didn't seem particularly aware of it, and it's something that we use quite a lot in healthcare. And I think it's very grounding. I've worked and tried to do changes for years and years until I started using quality improvement methodology, and really, instead of the sort of spray and pray approach, actually being quite rigorous in your approach, quite what is your intent and how will we know if we get a result. It really does make a difference, and I think that those questions, always you go back to, what are we trying to achieve? What is it that we're trying to accomplish? It really does narrow your focus, and particularly when you need to measure, did we actually get there, will make you think very carefully about what your aim is. Having a time bound. So when you're thinking about your project aims, and I know that we go around them, sometimes we know that this is a short period and we know that we're trying to go by 2020, but you might want to chunk up pieces of it. You may want to have 6 months and reduce so far in 6 months. You may have a specific patient population that actually that's where you think you're going to get biggest bang for buck, and some really concentrated focus on that. And part of it is about getting some wins as well, about getting some progress and seeing things happening. It's all about building will with your teams, and that's something that you constantly do, is about building will and the belief that we can make a difference. So we talk about, and that's the picture I was after, the model for improvement, what we're trying to accomplish, and then we're going to talk a little bit more about measurement in the next section. But we look at measurement around, are we achieving the outcome, and what are the processes that we're going to look at? How will we know that those processes are making a difference? And then about, what are the ideas that we have that are going to lead to the result? And then when we start to develop those, then we start making a plan about how we're going to test them and how we learn to test rapid cycles of improvement. As the national program, we've already kind of established what our outcome measures are related to our seclusion event data, and we've looked at our balancing measures, so we've done that. So when we focus on the next thing, we're going to think a lot about what processes are we going to change based on our theory for improvement. So improvement core concepts, the theory of knowledge, and we talked about that from Dr. Deming. Can we articulate why things are the way they are? Why do we have to seclude people? What drives that? Understanding that. And once we start to understand that and unpick that, then what are the change ideas? What are the things that we might start to do differently? What can we test that would make a difference to that? And that's how we build knowledge, is constantly testing, making that assumption, belief that what that belief is, testing it, seeing if it holds true, does it make a difference, and that iterative cycle of learning. I got rid of some of these. But when we talk about theories, it's not just about beliefs, it is beliefs, and we're using this in the scientific manner. We'll just skip through that if you don't mind. How is a theory different from a belief? From a scientific perspective, a theory can be tested. We can test those assumptions. We use theories to predict, and that's when we talk about variation. It helps us predict what the future is going to look like when we're looking at our data. If we don't do anything different, we should see the same results. At best, a theory is going to be a starting place, and as we start to develop our driver diagrams, and we're going to do a little bit of work on that in a minute, they'll change over time based on what you learn in your system. And there's no such thing as a perfect theory. We all have assumptions, and we're going to test them, and we're going to learn our way forward to improvement. So we talk about, we've had the co-design process, and we've now looked at a lot of ideas that we've generated together about some of the things that we think are going to make a difference, and we'll start to look at how we're going to test those, put those into our theory, into our driver diagram, and how we're going to go about testing them. So the components of a driver diagram we'll get into now is an aim. So you've got an aim statement, what you think you're going to do, how much by when. You're going to have some primary drivers, big concepts or system components that contribute directly, have an impact on that aim. Then you'll have smaller components of those primary drivers or secondary drivers, and there are elements from the primary driver which can be used to create change with the projects or specific areas that you're going to focus on. And then you'll talk about how those relationship arrows are, and that there'll be things that you think about. We talk about de-escalation might be one of the key primary drivers, could be reducing violence, and how you'll go through that. So if you were looking at a driver diagram and your outcome is looking at reducing seclusion, or maybe it's reducing violence, whatever your theory, you've done your aim. And we talk about, in this one, it's improving access to appointments. So one of the key drivers around improving access to appointments might be shape the demand, predicting your demand. Another driver for improving that aim would be around matching the supply, the clinicians to see the demand that you have. Another idea might be redesign the care process as primary drivers. Then when you come off of those, you'll start to get a little bit further downstream, and you'll think, well, what do I need to do to shape demand for appointments? I might need to decrease the number of, make more appointments available. Maybe it's hire more clinical staff to be available for those. It's a visual picture of how you're going to develop your change ideas, what your theory for improvement is, and then you go about testing specific change components. So this is one that we've done as an example for seclusion. So we've got an aim that we want to eliminate seclusion by December 30th, 2020. In this driver diagram, we've put some measures around it, but we thought of the big things that we thought were really important was about violence reduction. It was a primary driver. If we had a lot less violent incidents, that would drive our need for seclusion down. We also thought that maybe, this is just an example, if we had a developed workforce who was skilled in communication, de-escalation, and those sort of things, that would drive the need for seclusion down. We thought, what are other things? Safe care environments, environments that seem calm, space, that there is space for people. We think that may drive seclusion down. Effective management of challenging behaviours and things that have come out of that. So those are all sort of the types of things that we've looked at. We looked a little bit wider too, as around timely access. We think that if people had timely access and weren't waiting or weren't in the community and getting access when maybe they should be inpatients quicker, that might reduce seclusion. Involvement of the family and consumers in their care processes, and maybe having plans ahead of time, that might drive seclusion down. So then you look a bit further down, and we looked at some specific change ideas that would link to those primary drivers and things that you could actually take and test and try. So an example of that would be safety huddles. Maybe every morning at 11 o'clock for the next week, we get together and we look at all the people in our unit and say, are the people that we're concerned about? You know, are they going to get bad news? Are they not going to get leave? What's the plan around that? And you could test that for a week and see. And that is a specific change idea that will directly impact your violence reduction. When you get back and work with your teams, and in a minute we're going to get you to do some work on your driver diagrams, but one of the things is I always find useful as part of your improvement team, your group that you're working on, that they contribute to the theory, because they have beliefs, they have specialist knowledge. And one way to do that is sort of brainstorming and some post-it notes about the things that they think make a difference. And maybe you could go just as far as you do, the primary drivers of things that you think, and get them to contribute And then you can start to get all those ideas and then prioritise and start seeing about which drivers they would affect and where you might work on them, and then do an exercise around prioritising them. Are those ideas going to directly impact, cause a causal relationship to decreasing your seclusion events? And that's quite a good team activity. It builds will, it gets a lot more ideas from your team, and that they actually are part of the process. Good way of engaging your teams as well. So, you're going to get a bit of time to work on your driver diagrams, and we're going to come around there, a number of us coaching you, and start working around your theory, how you construct it, what it looks like, what you want to do, and then thinking about how you're going to go take that back to your teams and start working on it.